Hello, and welcome to the Security Nurse Podcast, the podcast where we talk about all things safety and security in healthcare. I am excited to have this next guest on today. When I started this podcast, I wanted to talk about topics that seem pretty logical to talk about with safety and security in medical settings, but I also wanted to bring some outside the box thinking and bring up some topics that maybe we haven't thought of before. And so that's exactly what this next guest does. I am so excited to have Maggie Ortiz on the show today. She has been a nurse for over 20 years, working in various departments, and has also been working as a legal nurse consultant. She has also been an investigator for the Texas Board of Nursing, investigating claims against nurses' licenses. And so she brings with her a wealth of knowledge and information, and she is now working as a nurse advocating for other nurses, helping you protect your license, helping you understand the legal implications, the scope of practice, and how to protect your nursing license. And she does that through her organization, Advocates for Nurses. I have seen so many instances in the news lately of nurses facing legal situations because of injuries that occurred with patients during violent encounters in the hospital. And so I really want to bring Maggie on to help give us some information on how we can document, how we can prepare ourselves, how we can be mindful of what we need to do as nurses to protect ourselves against further legal action resulting from these workplace violence scenarios and situations. So without further ado, let's jump right in. If you like this episode, please subscribe, share, comment. I love to hear your comments. I would love to hear feedback on what you liked about the show, what topic you may want to hear next. And so the more you engage, the more I can bring you good quality content. Let's get started. Hi, Maggie. How are you doing today?
Good, Sarah. I'm good.
Good. Thank you for being here on the Security Nurse Podcast. I'm excited to have you on and talk to you because you have a unique kind of niche that you're doing with advocating for nurses and the documentation. And so I would love to just kind of open it up to you and hear a little bit about your kind of backstory. And I'm asking everybody, what was that aha moment that has kind of put you in the position that you're in now, doing the work that you're doing now?
Well, thank you for asking. Been a nurse for 25 years, actually, this year. Hard to even believe. Started with my associate's degree, went to the ICU, ER, pre-op, PACU, endo, IR, cath lab, EP, structural heart. I joke and I say, honestly, everywhere but labor and delivery by choice. Because if I came to the ER, I'm like, oh, are you over 20 weeks? Oh, we can get you upstairs. Stand by, stand by. A lot of travel nursing, agency nursing. I did spend time at a border nursing, so I went to national training and I learned how to understand the rules and regulations and investigate nurses that were under investigation. Then went back to with an agency and did that process for a short period of time. I felt like we're not extending nurses due process. I left. My aha moment. Here we are. I created Advocates for Nurses. I started studying up on administrative law, not initially, but not long after leaving the agency. I went back to the cath lab just where I was comfortable, started working the bedside, but I became a civil expert. So my first crossover was as an investigator, my second crossover to legal nursing as a civil testifying expert. Some of the stuff I teach about, I talk about. So I saw another aha moment, or here's my aha moment. I was like, whoa, due process does exist, but in civil criminal law. And then I was
Yeah.
seeing things that were not extended to nurses sometimes, and I'm seeing it today. Lawyers, any administrative lawyer will tell you, you get a complaint from a board of nursing or the agency that's giving you the privilege to practice. More often than not, it will say within 15 to 35 days they want your response. And that was a year ago. That was 2 years ago. Do you remember what you had yesterday to eat? So some of
Yeah.
those things really changed my life. And I started helping nurses in their legal teams. At the time, I had my associate's degree. I was still bridging. So I did my associate's to my master's in leadership. Not a chance I'd ever be in leadership. God love everyone who can do that. It's just not for me. You spend some time with me. I don't fit there, and that's okay. I've
Hmm.
stayed at the bedside for 22 years of my 25 years. The last place I left was Cath Lab and EP. For the last decade, I've been primarily helping nurses and their legal teams. After that aha moment, I started a business, Advocates for Nurses. I didn't know what that was going to look like initially, but now, a decade later, like you talked about, I do a lot of education because the last place that I want a nurse to stand is in front of a board of nursing. I am not a lawyer. I'm not a lawyer. I am not a lawyer. I never give legal advice. All I do is education, and I
Hmm.
work more often than not alongside the lawyer and the nurse. There are a lot of times nuances of things that lawyers don't understand because they're not nurses.
Right,
So
that
I got
process, the nursing process, and how that flows.
yeah, I got really long-winded, but for the
No,
last
no,
several
it's perfect.
years, I really the pandemic, another shocker. I just some of the atrocities against us, I just couldn't stand and watch. And even more reason why I left the bedside and now I just do this full time. This is my full-time job and I'm pursuing law school. The minor detail. 50,
Yeah.
I'll be 52 this year. And so I'm just pursuing my JD, not 100% sure what that will look like, if it will necessarily be representing nurses, but it will be something along the line of making like real change for us so that any nurse in any state, when they show up, it just understands the process. And that could be through education with schools or, through, unfortunately, if you are an investigation, a service that can be provided, that your lawyer will have like those resources and everything. So I'm just
Available.
starting this journey, yeah, 'cause
Yeah.
with all the stuff that when a nurse reaches out, most nurses have no idea even they get that letter, what does that mean? It would be equivalent to any of us getting a diagnosis of, like, cancer or something. Sure, it can be cured, but there's a process, and do you
Hmm.
know it? And so all I do is provide educational resources to nurses, their legal team, sometimes just support, little trigger warning. One of the number one reasons why a nurse will attempt suicide is because they get a letter from a board of nursing. So
Yeah.
oftentimes it's just I'm listening, I'm supporting, here's some resources. Here's a video about being under investigation by the National Council of State Boards of Nursing. Have you checked that out? Have you looked at the resources in your own state about the investigative process? Like let's just back it up a little bit. Let's get you some education and tools that you need so that you can defend your license.
Yeah, I don't think in nursing school they go nearly in depth that they need to kind of surrounding that. It's like they kind of like, here's the scope of nursing practice and let's look at that and now we're moving on to the next chapter or whatever. And so there's not a whole lot of really good cohesive understanding, I don't think, that's really presented in nursing school about that. And you also made a, like another distinction too about how, you were with the board of nursing doing the investigations, but then when you got involved in kind of more civil and criminal cases, you started to recognize the difference, that there wasn't like a due process that was really done with the board of nursing. Can you speak a little bit to that? Because I think that's the other thing too that like a lot of people don't understand, is that the board of nursing boards and that licensure don't work the same way that like a court of law works.
Yeah, so they do have the administrative process like you talked about. And like you said, and I'm going to double down on that, we are not, we learn basics about the rules and regulations that dictate our professional license. We learn basics about some malpractice or negligence, but we memorize what we need to know for the test. We regurgitate that for the test because we are drowning in care plans, medical term. I mean, where to start, where to even start. Our learning curve is just
Hmm.
huge. So we reproduce what we need to know for the exam, but we're not criminals. So we don't pause there. Two states require what's called jurisprudence, Texas and New Mexico. I do not believe Texas allows you to take the CE one that is 6 hours with endorsement in this state if you don't hold a license here. But there are plenty of other entities who offer jurisprudence, and all that is basically is the intersection of your license and the law. it
Mm.
can be kind of confusing. So some of the stuff that you talked about, like within schools, that we don't learn, some of that stuff. And to your point, there's just a huge lack of education there. And then, like you talked about when I left the board, so that was it was administrative law. It's a different type of law, to your point, than civil criminal. Now, I don't speak at all about anything criminal. That's for sure not my wheelhouse. Civil.
Hmm.
I've been a testifying expert for civil. But so due process as it pertains to a nurse that's under investigation or the board of nursing, that entity is administrative law, where more often than not, you're guilty and you have to prove your innocence as opposed to the other way around in most other types of litigation, because the board is there to protect the public and not us. And I don't think, again, to your point, in school, that I just think we kind of skip over that little minor major detail, and we just don't realize that there's just not like really anyone out in the universe then who's there for us. And I'm not,
Hmm.
of course we have to have nurses who practice safely. Of course we have to have an entity that's going to oversee, but there has to be some due process. You have to be able to be afforded, let's just say, for example, you took care of someone a year and a half ago, you're getting a letter on or about this date at this time while you were working at Sunnyvale Hospital, patient NB, number 245, you failed to respond to that blood pressure of 90 over 50. Tell me about it. Go.
Yeah, and you're like, huh? And so what's kind of that process in like do you get access to then like the EHR, like the notes afterwards so that you can kind of look at that stuff to help jog your memory or understand that like before you're even going into some of these cases?
So are you asking me, does the nurse who's received a
The
letter?
notice, yeah.
Yeah. So if you don't ask, it's always no. So this is why you have to get legal counsel. This is why you have your representative that you call from your professional liability insurance the second you get that letter, and you start looking at lawyers in your area. No different like if you came out of the house and it's snowing and your car has, been wiped out. You would call your insurance company to say who's going to come out. It's the same situation. So you get that lawyer. That lawyer will be asking for your full and complete file. And then
Mm,
you shouldn't be speaking to the board. It should be through your legal counsel. Now, every state is different. Some states will not send official allegations, and I don't want to get into too many nuances,
yeah.
but if you don't get official allegations as the investigator, that was something that I would generate in the state that I was from. On or about this date, that time, what I just read to you would be what I would be generating from the complaint that was sent in. Now, in some states, the investigator looks at it or it gets sent in. It would be a nurse investigator looks at it. There may not be evidence. Say that there's video evidence that you did something, probably going to get that official allegation. It's a little wishy-washy, not 100%. The board may reach out to you, say, hey, we want to talk to you. Would you come on down? Or we're going to set up a Zoom. We're going to let you see some things. We're not going to give you, because we're not really opening up an official case, but we're going to let you see some basic things. And we need to know, kind of let some stuff that's happened, what's going on. North Carolina is one of the states that does do that. I consider that to be just culture. Their board is the only board, I do believe, in the United States that has just culture written into any of its language as it pertains to the investigative process, which is different. So, to your point, do you get to see the records in administrative case? If it's sent to the board of nursing, you have to ask, and you should absolutely not be writing anything down or telling anyone. Because again, do you know what you had yesterday? Now, it may be something that you do remember. It was it was a bad outcome. If it went to the board of nursing, more likely than not, you probably have a memory of it. But can you come up with facts? You cannot. And that's part of my training when I went to national investigator training. And this is all like science researchable. Every second you're away from event, and everyone knows this is a common sense argument, your
Hmm.
memories of it, and every time that you replay it or resay it, you're like interjecting, you know what I mean? You're
New
inserting things that,
details and
yes.
trying to fill the gaps that your brain's not.
Yes. So no, I would like to see the medical record. If you're saying that, okay, let's just say I gave, you know, 1,200 of Plavix and I was supposed to give 600. Let's look at it. Let's look at the MAR. What did I document? It looks like I was told to load the patient with this. It looks like that, but you see what I mean? How could you know that? So
Mm-hmm.
you page 54 of the medical record, and now you're talking to someone who's not a nurse. Now your investigator's not a nurse. Why?
Mm.
So that's one of the first things I look at with the nurse and the lawyer. And they're like, what do you mean? I'm like, do they or do they not have RN behind their name? Because if they're not, then some of the stuff that I'm helping the nurse and the lawyer with is it's a pixis. I said, you can't say that word. And they're like, what do you mean? I said, do you know what a lawyer did when you came to this job? Did you know what you did not? So there's a picture of the medication dispensing machine because you have to paint the picture, you have to bring them into your environment. So
Mm-hmm.
sometimes those are some just basic things that I bring, that I help with the nurse and the lawyer with to make sure that those nuances are spelled out, that it's really painting the picture of what was happening.
Yeah, and so you make that distinction of really having kind of that plain language, factual language, and not necessarily like name brand type stuff, and being more descriptive in what you're talking about, right?
Yes, because ultimately, who's your audience? And if it's going to go to a quote unquote nurse trial, there's going to be a judge and mediator. What is the likelihood that they're going to be a nurse or a doctor?
Mm-hmm.
So who's your audience?
Got it. And kind of going to that, to the documentation piece of things, and jumping into that and kind of diving into that documentation for nursing, like why is it important? Well, I mean, why is it important for the documentation to be accurate? And who's your audience maybe when you're documenting?
I wanted to jump in and scream and yell because this is my total wheelhouse. This is like a huge big deal. Oh my gosh.
Getting you
So,
going now.
uh, so I can pursue law school. I can do all this stuff. But when it comes down to the nutcracker, when you're standing and insert any of these courts of law, it will come down to the words that you did or did not document. It really will. Your memory, the things, paint a picture of what was happening because now it's 2 years from now, a year from now. And the other thing, if you're involved in civil litigation, let's just say it's something that happened civilly. There's a case, and now let's just, you already talked about the other possibility, the border nursing, but let's back it up. You're working on the floor, and this is something that I write about in my book because that's help I'm a nurse, I'm being deposed. That's civil litigation. That's not border nursing.
Mm,
That's malpractice. That's someone had a bad outcome, and there's like more often than not, there's damages. There's
mm-hmm,
duty, breach of duty causation, and damages in civil litigation. Each threshold in the court of law is going to be very different. For example, is the O.J. Simpson, right? The criminal, the civil litigation was very different, right? Because the
mm-hmm.
threshold that has to be met is very different. So, civil litigation, you're on the floor. They call up, hey, no big deal. So there's a case, come on down when you're ready. Just, and you're going to be deposed next week. You do have some rights. And
Mm-hmm.
so some of the other things it will come down to, and you know what you're going to be looking at in the risk management in the lawyer's office? The documentation.
Documentation, yep.
Yep. What you did or did not document. You're going to be really uncomfortable
In that,
when you
yeah.
get on the stand. And now your documentation will be literally, when I say big screen, I mean literally on the big screen. And
Mm-hmm.
maybe you're on Zoom. Maybe you literally are sitting in a courtroom. But depending on where you are, the deposition, there's not going to be a jury. If it goes to trial, 100% there's going to be a jury, but that deposition is you are under oath, and the jury does get to read your deposition, gets to see all the exhibits, gets to see the video of your deposition. So we get some visuals with that as well. And just remember that type of litigation is not your peers, right? These are people from the community. So
Mm-hmm.
remember when you're at the grocery store, look around because these are the people that are going to be judging you. So remember that. So what you do or do not document does really matter. You do need to take the extra time, especially if there's an incident. If there's a code, oh my gosh, and you are
Yeah.
the primary nurse, please write some words down. Number two, if there's anything, the stuff that you do, anything around violence. Got a nurse reached out in her legal team and she was saying things, and I had never heard this before, that they had video footage of her hand too close to the person's uh, neck. You know
Mm-hmm.
what I mean? So there was video,
Yeah, because
but there,
security probably had a body
who
cam.
knew? Who knew?
Yeah.
So, but the question bears, like, what happened 30 minutes before? Because there's no video footage of that. So did you document it?
So how do you, what types of things, like just taking that kind of scenario, because I think, and I was going to kind of ask you, like, okay, what's your documentation, like why did you put restraints on a person, right? And so what's your documentation like up to that, or even this instance with the nurse and the footage? So what types of things, maybe not what types of things, but kind of what's like a rough outline of, here's like bullet point things you want to make sure that you're documenting in your notes in those types of situations?
Great question. Great question. Because if you take someone's rights away, which is what you're doing when you restrain someone, and physical and chemical restraints are very different. If you use a chemical restraint, oh my gosh, oh my gosh, you better have a very clear understanding of what that is. And in every
Before you do
setting,
it.
that could be different. In a long-term care facility, that could be giving a benzodiazepine. I'm sorry, that could be giving Benadryl. And I've seen that. And that nurse was charged criminally
Oh,
because she
wow.
chemically restrained that patient. She got her nursing license revoked. That is considered a chemical restraint. That's a big, huge deal. And I know I'm getting real serious because this is real serious stuff.
Yeah, no, it
She
is.
did get her license revoked. And that's OIG. That's a whole nother animal. We're not even going to go in.
Well, and I think just to make the distinction, because physical restraint, those can be taken off easily, put on and off easily. When you give a chemical restraint, you're essentially altering someone's in like being, right? You're altering their mental state, you're altering the way their body works, and it's something that doesn't, you can't easily reverse that, right?
And there's a whole policy around that. There's civil rules around that. There's criminal rules around that. I mean, Google your state patient rights. If you're involved in, and this is where it's really important for when you work in certain modalities. If you're working in an emergency room, if you're working inpatient psych, these are things that before you're doing that modality or while you're doing that modality, please introduce yourself to your job because those that kind of type of litigation and you need to know what the policy is. I'm not deviating from it. I've worked in the ICU to your point, and every 2 hours we had physical restraints on someone, and I had to write why am I physically taking away this person's rights?
Mhm.
They have an ET tube, they have arterial lines. More often than not, in a critical care setting, it's because they have life-saving things that if those are removed could cost them their life. So that document, that's a gift. Now I don't have an ET tube. That's a whole nother animal. You're not in a procedural area because procedural areas are different as well. I work cath lab and EP. If we're putting a pacemaker in or if we're doing something, we are 100% going to put reminders of physical restraints on you because we cannot have you while I'm giving procedural sedation reach up. So
Mhm.
those every area is going to be very different and you need to understand what the policy says at your organization. I didn't say culture. I don't care what the culture is. I do not care what the culture is. Another
Yeah.
example on a procedural table, very narrow, doesn't matter where you're at. IR, cath lab, these are areas where you're introducing sedation, and so they do have to have a body strap on them so you're not obstructing the procedure. In the cath lab, that could be different because you're not going to put it over their hips because we're accessing the femoral artery. It could be, but whatever that is, because if that patient falls off the table or something happens and you didn't use that restraint, so that could swing both ways as well. Did you use a physical restraint to keep the patient safe? The other thing is are you using a physical restraint appropriately? And what is the indication? Why are you doing it? It's always going to come down to patient safety. The
Right.
chemical restraint is every 15 minutes because that's considered behavioral. More often than that, that's a one-to-one situation. If you can't, then you have to call a code, all of it, a rapid, a code. You have to get the help you need, 911. No one wants to hear that stuff, but now you're standing in one of these courts of law. What would be your defense? There's none. So you have to do whatever you can. And you know, if they're one-to-one, they don't have to be a nurse. You just need someone to physically watch them, and that could be anyone who has been identified that is able to stand there with them. It could be security, but you do have to use whatever in your environment. Most often than not, in the EHR, there are prompts that will walk someone through so that you don't miss the documentation.
Mhm.
The other thing that I see nurses reaching out to me in some of these poor practices, documenting that you're checking restraints in two different rooms. Let's use the ICU example again. Can I
Okay.
be in room 1 and 2 at the same time on the hour checking those
No. Yeah,
so
so you
why are
gotta
we
kind
doing
of
that?
stagger that a little bit when you
Well,
document
when
that.
were you really doing it? Just go ahead
Yeah.
and just do it when you're really doing it in the room. If it's not on the hour, that's okay.
Mhm.
Your leadership should not be coming back, and unfortunately, I've seen this, and now it is on the big screen, and now you will be asked. Now you're unnerved. You're in an area that you're not comfortable with, and now they've already shown that you were fraudulently documented, because that is fraudulent documentation, right?
Mhm.
It
Yeah.
is.
Yep. And then do you feel like kind of those that click box documentation is enough, or do you really recommend that there's still kind of like a free note that's put in there that describes the situation?
So for an event or just in general, if I'm just taking care of someone and there's nothing going on, I will do an opening note. Some of that could be tied into just my handoff. So some of these EHRs have the ability. I open up that template. It's going to walk me through who am I getting a handoff report from, and then if there was something that was going on significant, I might drop it just in the notes there.
Mm,
What that prior person said. But then outside of that, I don't have a problem with checkboxing because for lung
okay.
sounds, if we all learn what WNL is, you have your degree in nursing.
Yep.
So an expert nurse who would be giving their opinion or opining about what you did or did not do wouldn't be what's WNL? No, we all know. Now, to that point, if the patient comes in, they're on 2 liters of oxygen, that's a deviation. When I first take care of them, I W and accept on 2 liters, and then I'm assessing their lung sounds. It is okay for me to put the deviation and then still the same assessment and not write a note because it's not changed. I
Mhm.
identified that the doctor has in their history, their COPD, then do you see what I mean? We're good.
Mhm.
If there is an incident, any incident, and I don't care what it is, you should be writing a note, quoting as much as possible what the patient did or did not say in quotes in some kind of organized fashion. I'm old, soapy is an, subjective, objective, go through
Mhm.
that just so that you're doing something in an organized fashion. All your communication should be S-bar, and so your documentation should flow in that manner as well. Situation, background, assessment recommendation. This is a national standard. The expert nurse, I call the wolf nurse, who will be, just imagine, because you talk about who would you be documenting? How would I be documenting? I would be documenting to give the expert nurse also the gift to say she did what she was supposed to do, so we're done here. That's how
Mhm.
I would be documenting. Document like you're the expert nurse that's going to become looking at this case, and that there's going to be no question about what you did or did not do, that you would have to come back and say the nurse did not deviate from the standard of care.
Gotcha. Is there certain things like when you're documenting that you would want to avoid documenting? So it's not and not and I guess kind of like clarify, and maybe you can clarify a little bit further and you kind of hopefully understand what I'm trying to
I do.
ask you. Okay.
I cover it in my charting
I'll
class.
let you take it. That's why
Yeah.
we're doing this together.
So I do cover that, and I have 2 charting courses in this. That is something that I do talk about. Example, Bob walks into Sally's room, patients, assault Sally. You're not writing that patient's name and the other patient's name. You can write that something happened, but you're just not putting their name. If there's an incident report, you will write up an incident report, but you're not going to reference that in the medical record. Um, it's not your journal. The facts. In an organized fashion, painting the picture of the care that was provided. It's a form of communication between providers. I should be able to walk right behind you. Something happens to you, God forbid, you're 11 months pregnant, and you're like, got to go. I'm giving birth right now. And I'm like, absolutely, I got you. Tap out. I'm going to tap
Yeah.
in. For the most part, I'm going to be able to fall in right behind you, not only because I've done this modality, I can look at some basic things, and your charting is up to speed for the most part, that I can fall in behind you and just pick up where you left off. So that medical record that we kind of just take for granted is a big, huge deal. It's a piece of communication. It helps to save patients essentially and make it be witty. No patient, we've all been there. No one wants the nurse standing behind the computer, but you make it about them. Hey, Bob, oh my gosh, 12 people have your same name. Give me some other idea. Make it about them. They want to feel like they're the center of the universe and you want to do that, but you tie that into their safety and oh my gosh, got to get that note in. We want everyone to know about your penicillin allergy. Tell me what it was again, Bob. You know what I mean? You make it about them because heaven forbid, we've all seen it on the news where and you're pulling in good work habits where you're doing things in real time,
Time. Yeah.
protecting yourself and the patient.
Yeah, I was gonna ask you about that because there is like this awkwardness, like when you're standing there and you're kind of free typing a note, about like what's going on, like back to the blood pressure. We can use the blood pressure example. Why didn't you respond to this low blood pressure, right? Well, maybe I did go in there and I rechecked it manually or something like that. But and so then I put the new blood pressure in, said that I checked it manually. But do I maybe add, like, this is like the patient's disposition when I found them, right? Like warm and pulses nice and strong and awake and alert and that kind of stuff. Adding that type of information to that note, but then doing it like while you're in the room and not making it kind of like that awkward, I'm not ignoring you, I'm just trying to type this note in real quick kind of thing.
No, it's a very solid point. And try to as much as possible, but we give the care first. If you can't do that in real time, totally understandable because I'm getting a manual blood pressure, I'm doing those things. When you capture it, if you possibly can get that in the medical record, and then that's your reminder where you can come back and maybe write a longer note. You can put late entry because me as the wolf nurse or you as the wolf nurse, are you expecting me to do two things at one time? You're not, and you're not going to give testimony. You know what I mean? You're not going to write that up. You're going to be more concerned with, okay, let's talk about it. So the pressure was what? The pressure was 90 over 45. I come back, well, what was the heart rate? Were they oriented? Did you do orthostatics? What would a prudent nurse have done? Do I have an order for an orthostatic? Stop it. There's a policy on your floor, I promise you, if they're inpatient to do orthostatics. If not, you're a prudent nurse. Call Dr. Bob or the resident, whomever. Hey, this is their pressure right now or whatever. Or you do a repeat one. You're not going to do one pressure and be like, oh my gosh. You do a repeat pressure, it's on the other arm, it's consistent. You know it's real. Then you're like, hey, I need to do orthostatics. And then the orthostatics are positive or negative. You can see they have 3 antihypertensives that are ordered in 10 minutes. Probably
Mhm.
not going to be given those. So I'm going to call Bob, but I'm all Dr. Smith. But Dr. Smith has 300 patients. I have 6 or 3 or 4. So I'm going to use my background. I'm going to use my S bar. I'm going to first go, hey, I see that he's on. I'm gonna look in the chart. Okay, I see we're in AFib. We're on, this is why we're on. He just had a stent placed, so I know this is standard of care. Okay, okay, okay. Um, okay, he was stented 3 days ago. I'm gonna pull some things together and I'm gonna call Dr. Smith and say, hey, patient in 54, post-op day 2 or 3, whatever, had a stent placed to the RCA. Blood pressure is this. I did do some orthostatics. It looks like he's been still with some AFib sustained up to the one. You got 3 antihypertensives ordered. Coreg is probably going to be the one you want to continue, right? I mean, just because, again, you're going to go through that process with the doctor, but you're going to do a little bit of research before you call the provider. And then you're going to give yourself credit for that because most places have some form where you could do that situation background assessment when you're calling the doctor. If not, create a smart phrase for yourself. You can create some smart phrases and you can just say S bar. You can take that, put that in the note, and you already know what you did. You're dropping that in quickly when you have the time to do that, and you can do a late entry, but things you should try to document in real time whenever possible. I've been a nurse for 22 years at the bedside. I told you all the different places. I've been a travel nurse. I've been agency. I would have to go back and do some documentation. I would try to write something down, and I'm going to get real crazy. We were on paper.
I started that way. I remember writing out my DAR notes.
There you go. Or soapy or vomit. I mean, they're using, I don't care, whatever you're using to write an organized note. Now, if it's at the end of your shift and you're doing that every single day, something's wrong. You're either taking too many patients, you're writing too much, you're not, your workflow, and get with the nurse informatics and just see, because sometimes they can wrench in different templates or
Or like
something.
shortcuts type
Yes.
things. Yeah.
Like in the cath lab before doing a TEE, why am I writing out all this stuff? Nope. Wrench that template in. This was all the stuff, and then it's prompting me through, and we're done. So it could be just some workflow things that you just need to adopt. We don't learn this stuff in nursing school. No one's expecting you to know all this stuff when you go to the week training or general training. I mean, stop it. You're touching and feeling something maybe for the first time that you're not used a lot. So sitting down with someone who does that informatics might be, a gift to you. The other thing is that when I go to different environments, I've had I've called like the Epic hotline and say, "Hey, mirror my access like Nurse Sally," because I saw
Mm,
that she had all that stuff already wrenched in. So when they
mm-hmm.
set me up front facing in that area, I already had that stuff wrenched in. So that helps with time management because this all swings back to what? The documentation. Because if you're prompted to do that stuff, now there was something that went wrong during a cardio version. Looks like this was all standard of care. I mean, nothing the nurse did. But you missed something. There was no jewels, but you had that prompt in there because it was
Mm-hmm.
walking you through.
Walking you through that. Yeah.
Documentation is, I'm going to beat that. I chose to create courses because I can continue to assist nurses and their legal teams, right? That's band-aids. If
Yeah.
you don't document the words, and I've seen that unfortunately. And then I'm like, well, what'd you write? I'm like, nothing. Not a word.
Yeah. Yeah.
And I don't care who tells you not to write any words. I don't care if the chief nursing officer comes and tells you. I was a prior investigator. No. I don't
Mm,
care if the president comes and tells you. I don't care who tells you not to write words. You have to document. Someone tells you that, I want you to go down to legal and to risk management and ask them the same question and call the board of nursing.
mm-hmm.
Or then do some basic research about even HIPAA and what that means. We are required to maintain the medical record.
Yeah. What are some good resources? So you mentioned IT, like getting with your IT person. I think that's fabulous. I don't think I even thought of that. I went through, the Epic training when I first, well, I've been through several because a lot of places that I've worked, I'll use Epic. So as I, moved around and redoing that Epic training, but even like you said, like talk to risk management or something like that and kind of get a better understanding, maybe going to them and saying, hey, how can I document, in a better way to protect my license? What are some of the things that you're seeing? What can I be really, mindful of when I'm documenting? So reaching out and using those resources that you have there within your hospital. I don't, or just your, organization, whether it's hospital or not a hospital, and using kind of those internal resources. But then, what are some other external resources? So you have the documentation course, and we'll definitely like drop the link and everything for that, so that anybody that wants to do those courses can do them. But what are some other like external resources that are really helpful for nurses and providers to make sure that they're accurately documenting?
Within the organization as well, a policy. We'll start there and then we'll go external.
Hmm.
An example that I use is also like a PICC line dressing change. It's a national standard that's going to be adopted, right? So your organization is going to adopt a policy that you're going to be held to. You look at
Mm,
the policy, you create a smart phrase, and now you just drop that into, because how many times are you doing a line dressing change? Why are you retyping that all out? And then if you change up your Taggart or whatever you're using, an Opti 1000 because they have an allergy, whatever, that's your only change.
mm.
So if you're in a specific modality, labor and delivery, ICU, what are some of your external service options? Those associations. Because when the wolf nurse is called, you know where they're going to pull their resources from? The
It's
last
from,
five, science, because it's all science from there. So why not start if you're in a modality, the cath lab, EP, you're doing certain things. The other thing that you could do as well in your modality, let's just say I do labor and delivery. What are the top 10 litigious cases that nurses have been involved in my area? And
hmm,
labor and delivery is a big one for obvious reasons. And
yeah.
that type of litigation goes for 18 years because there's more than one person involved with that. Using, working back prior legal cases in your modality to make sure that you don't do that. One of those would be like Fenergan. That went to the Supreme Court. Anyone who's given Phenergan in my career, I've seen it go from, you know, administering, shockingly enough, 100% 25 milligrams, but I've seen 50 down to 12 and a half to now. You will never see that. I don't
I know.
think.
I
Not a
would, because
chance.
I've been out of the bedside for a while, and I just realized that I have not given a single dose of, because I started in 2000. We gave Phenergan back then, and I'm just now realizing like I haven't not given a single dose since I've been back at bedside.
Not a chance. It's been to the Supreme Court. So you're going to give Zofran first if you have intractable nausea and vomiting, depending on the setting. But now I know that policy. So do you think I'm pushing Phenergan ever? Not a chance. And then when I'm documenting it as well, if I am giving it, it's normally mixed by pharmacy. If I would have to mix it and I'm mixing it, depending on what it is, and it doesn't matter what it is, and a 50 runner, you can be 100% on document that. And you know why? Because I know that's been to the Supreme Court. Why do I know that? Because I know, that it's been pretty much attached to every association. So once you know your modality and you get hooked up with the American Academy of Anesthesia or association, or you get hooked up with, I don't know the labor and delivery. I should, gynecology, gag or whatever that, you know what I mean? These are the things I promise you that are putting out statements. Now, do you have to meet with them or no? They have newsletters. Set your alerts, read your newsletter, catch yourself up to date on the new science so that you understand what, like, they all were putting out that Phenergan went to the Supreme Court. Every nurse should have been paying attention to that. Every single nurse should have been paying attention to that.
Mm-hmm.
I can promise you, if you are a nurse, you have given it, and this is the IV form of it,
Right.
at
Yeah.
some time in your career. But if you know that it's gone to the Supreme Court, and then it's black boxed, and then now you understand that when you go to the Pyxis and you hit you okay, because there's 3 layers normally on the Omnicell, and you know what they just did? They protected themselves and not you. So who's going to be held accountable if something happens to that patient? Because the organization programmed in, you did the other, clicked yes, you knew it came out with a vial of normal saline, another telling you it needs to be mixed. If something happens, the onus is not on the organization, it is on you.
I actually have a question about that because, like, some of the like antibiotics, like having to mix those and things like that. So, do you recommend like like when you have to self mix something like that, charting that?
So I wouldn't be mixing anything unless I had to. Now, add a vial for let's say Ansef or Zosyn, that's very different. It was dispensed by the pharmacy with a label on it and I'm adding a vial. Very different than I'm pulling the doctor. More often than not, I only see this interprocedurally or an emergency room setting because other than that, why are you mixing a drug? But I'm in a procedure, I'm being asked to mix Neo. So I have to do that. I should have another person look at that. But you should try not to at all, depending on your setting, to mix drugs. Let's go back to that Neo. What was pulled out of the Pyxis or the Omnicell, we have a nurse cart with what the concentration was and how to mix it, and what was programmed in the pump were all different. So had I not been prudent, looked at what was pulled out, what was on, you know what I mean? And that was
Yeah.
programmed, and then I did have it double checked with another nurse. Normally, I would just we needed it emergently, call down to pharmacy, have them mix it up. But always, if you have the ability, do not mix drugs. Never mix a drug. Are you a pharmacist? You're not. That's not your modality. So people get egos like, I didn't do it, but not me. And when I worked
Yeah.
at a freestanding emergency room and we didn't have a pharmacist on staff, you can be real sure when it was anything pediatric related. I called the big hospital. I'm like, hey, pharmacist,
Mm-hmm.
did you say Bob? Oh, here we go. I'm writing that in the medical record. Thank you so much. Appreciate you, Bob. So, Bob, I have this drug. This is the drug. I want to make sure this is the dose. And then I'm writing that in the medical record because if it was wrong, I'm doing a couple things. I showed that I'm prudent. Because what did
Mm-hmm.
I do? I picked up the phone and called the pharmacist, who's the
Mm-hmm.
expert in that. So the expert nurse would see that, wow, there's a level of prudency. I verified, and then they can see in the note, now the patient had a bad outcome or something happened. Is that truly because of something that I did? Probably not, because I did do some different steps, verified it, looked in the drug book, whatever it is that I did, making
Yeah.
sure, but I don't mix drugs. Now, I can say this 25 years in, when I was a year and 2 years in, and there's sometimes where we are in settings where we are mixing drugs, and I'm not talking about adding a vial when pharmacy has put a label on it. I'm talking about you pulling the drug out, you mixing it, you better slap a label on that.
Yeah, like mixing an insulin drip or
No,
a
not a
Narcan
chance.
drip.
Oh my God. Oh
Well,
my
but some of these smaller hospitals end up in these situations like on night shift where you don't have a pharmacist there.
I would be reconsidering my job, and there would be no way. Like insulin is a high alert drug. So
Yeah.
the other thing is that before I would ever do that, and the responsibility of the organization would make sure that I would have to go through some training. That
Mm-hmm.
they would have to the organization's onus then as the expert nurse, I would then say, okay, this is a rule setting. So there is different litigation. There's like under civil procedure laws, if it's some states do want a nurse with us to be down to that specific where it would be a rural nurse. So I'm looking at a rural case. The onus on the organization then would be, what did you do to educate this nurse who's not a pharmacist and you don't have someone on nights? Because I wouldn't be able to take that job. And the next question from the board of nursing would say, did you take the job? Even though they were not training you to do that? And you didn't think there was going to be a bad outcome? So did you ask for your training? Did you go to the board of pharmacy and see what it is? And even I've seen this where there are certain drugs, and this I've seen with IV hydration businesses where the drug has to be mixed under the hood. The nurse did get reported to the board of nursing because they didn't reach out to the board of pharmacy to make sure that the drugs they were mixing, they could, but it had to be under a hood. Well, we're not pharmacists. We don't know that. Now, had the nurse reached out to the board of pharmacy, made sure, had that layer of protection, had the expert nurse looked at that, had the same or similar modality, would have said, mixing under a hood, per the board of pharmacy, nothing to see here, folks, we're done.
Gotcha. Yeah, so it's really understanding what medications are within your scope of practice really to mix and be able to do that and unfortunately not necessarily rely on your organization. I mean, I think a lot of people put trust in their organizations to think that they did all of that legwork for you. So, of course, they wouldn't ask you to do this if you were allowed to do it. And so there's no second guessing. But unfortunately, I think we need to be a lot more mindful of that and second guess things.
Yeah, and it's within a nurse's scope of practice to mix any drug outside of an anesthetic, unless you were obviously a nurse anesthetist. So that's where it gets tricky, right?
Mhm.
We can mix any drug, but then have you been educated about that? Where are you mixing it? So there's these other things. I just remove that layer. I just don't want that level of responsibility, even in a code. I've worked at large organizations where the pharmacist did show up for the code.
Mhm.
Like, you're gonna let them hand me a drug? I sure am. I'm gonna look at it, Bob. Tell me about it. Where'd you pull? I mean, that's my only job is the pusher of the drug. So we're looking at it together. Thanks. They're the experts, right? I mean, get
Yeah.
out. You
Yeah.
want that other layer of protection. And then during a code, if you don't think this stuff's going to go wrong, right then and there, and then you're looking at drugs, they're getting mixed wrong. So I always suggest do not mix drugs if at all possible.
Possible.
Call the
Okay.
pharmacist, have them mix it like the phenergan. Unless I need it emergently or something, let's just use that example because I do know it's been this to Supreme Court. I'm calling down to the pharmacy and saying, there's an order for whatever it is, Pentagon, tell me what's gonna be ready, but if the pharmacist says, "Oh, you can mix that. Thank you so much. So let me know when that's gonna come on up, but I'm gonna need you to mix that. I'm not comfortable." Whatever it is.
Mhm.
No, we get to control some of this stuff, but you just have to advocate for yourself and in the practice, and then always double check something with another nurse. Always, always,
Yeah,
always.
absolutely.
That's your layer of protection, even when you even in procedural areas. I had a pharmacist, or I was on a pharmacist podcast, and I ended up interviewing her basically for us for procedural areas because it's common for us to hand off the controlled substances. Hey, I'm going to go to lunch. I'm breaking you out for lunch or whatever.
Mhm.
Here's
Yep.
50 of fentanyl, and here's 2 of Versed, and it's just like a honesty system. And I said, oh, tell me about what should be done. And she said, anesthesia actually signs over the whole Pyxis. I said, wait, what?
Mm.
I had no idea. And so they have the layer of protection that's already worked into their workflow, but we don't. And
Yeah.
so I've worked procedural sedation at so many different places. now my practice changed where we open up the medical record and I'm like, hey, Sarah, here's 50 of fentanyl and here's 2 of Versed. And I'm just making a note, handing off 2 milligrams of Versed and 50 of fentanyl to Sarah. I sign out, you sign in, accepting, same. I walk out, I go to lunch, and then if again that wolf nurse is looking at this because there's been drugs that have gone missing and I haven't seen this, normally anything I'm talking about I've seen, then there's no question. Sarah didn't take the drugs. Because now it's 3 weeks from now. You're like, hey Sarah, you've done 100 cases since this day.
Mhm.
So tell me about this day. And you're like, okay, well, let's look at the medical record. Well, it looks like I handed those drugs off to Maggie at 12:27. We're done here. Sarah's done. And Sarah's moving along.
Yeah, no, that's a really good point on handing off those medications and making a note about that and just ensuring, kind of that chain of command, I guess is lack of a better
Chain of
word, but
custody. Yeah.
chain of custody. Yes, there
Well,
you
she
go.
even told me I didn't realize that the pharmacist is responsible for all the drugs in the building. Now that's obvious when I say it out loud,
Yeah.
but I was like, oh, oh, that's why you're always coming down and because the DEA is like, hey Pam, so yeah, the DEA's here. We just want to know about your people. So the DEA is knocking on their doors,
Yeah.
right? Not ours. I mean, we're eventually we swung into this, so that's why their urgency is because you'll see like sometimes in people who work in procedural areas, you're still in the case and they're calling you, hey, so an hour ago I'm still in this case. I haven't wasted those drugs yet. I'm actually but I'll get that I promise you when we're done with this.
Yeah.
Because again, they get some alerts or whatever, and I'm exaggerating, but at the end of the day, or you get the nasty gram because you did waste the drugs. The patient was coding but that was written down somewhere maybe, but it wasn't put back into the Omnicell or the Pyxis that I'm going back and I'm like, oh my gosh, we did waste that. Thank you for bringing that to my attention. I'm going to go and make sure that that's wasted the appropriate way.
Yep. Yeah, absolutely. I know that we are getting short on time. I think we're just going to have you back at some point,
I
which
agree.
darn, no sad eyes there. Where can people find you? How can they get in touch with you? I'll make sure that we get all the links in there, but what's the best way for people to get in touch with you?
So I'm on every social media platform. I have my own website, advocatesfornurses.com. All my handles are the same, advocates for nurses, advocates for nurses. Nothing crazy. So wherever you're at, whatever you need, you're never alone. I know that we didn't get a chance to touch on a lot of the stuff that I mean, what you're doing some amazing stuff in the world, as well. But any nurse can reach out to me, all those platforms. I have lots of content on TikTok. You're looking for some basics, nuts and bolts, getting down to the nut cracking, check out TikTok, LinkedIn, a little bit different, some of the stuff I put out there, but all social media platforms. Thank you for asking.
Yeah, no, absolutely. Because I think it's a big topic. It's a complex topic, and it's important to kind of know where those resources are and how to get a hold of people. So yeah, we'll make sure that your link is in there. I'll put whatever other links we need to put in the show notes so that people can find you and take your trainings and dive in a little bit deeper. But yeah, we'll definitely have you back, Maggie.
And I'll give your audience a coupon, whatever you want to name it. We'll do that. And then you can just share that. It'll be a discount for the charting course. And then I do have free downloads, Understanding Border Nursing Investigations, Charting Tips to Protect Your License. And if you want to be a legal nurse, that's the other thing I do. I help nurses cross over. Those are all free downloads off my website that anyone has access to. Again, you're never alone. I do think having a basic understanding about the border nursing just helps everyone.
Yeah, absolutely. Well, thank you, Maggie, for being here. I hope you have a great rest of your week, and we will definitely have you back. I know we will.
Ditto, and I'm gonna have you on mine, so.
Okay, definitely.